Good evening, everyone, and thank you for joining tonight's webinar on the CoC Self-Audit tool. Next slide, please. This is just a brief review of webinar logistics. All participants will be muted during the webinar. Questions, including any technical issues may be experiencing, should be submitted in the question pane as illustrated to the right. At the end of the webinar, we will answer as many questions as time permits. As a reminder, please complete the post-webinar evaluation you will receive via email. Recorded content will be posted to the ACS Cancer Surgery Standards Program playlist and the website in a few weeks. Next slide, please. So I'm your moderator for this evening. My name is Anthony Villano. I'm a surgical oncologist at Fox Chase Cancer Center. I'm also the CLP for our center. Next slide, please. Here's an overview of the program objectives for tonight. Our webinar will focus on the new internal audit process for programs, which we'll be conducting for standards 5.3 to 5.6. At the conclusion of the webinar, participants will be able to understand the internal audit process, describe how to utilize the CoC internal audit templates, and gain insights into accurate and compliant case auditing. Next slide, please. This is our outline for tonight. After the introduction, we'll be moving into an overview of the new self-audit process. This will be with Dr. Bleznak. We'll then discuss auditing demonstrations of compliant and non-compliant cases using the tool. That will be with myself. And we'll discuss considerations for registrars with Carrie Antonelli. The final part of the presentation will be a panel discussion with a Q&A for all the participants. Next slide, please. So I'd like to introduce our panelists. We have two great speakers for tonight. First is Carrie Antonelli. We're fortunate to have her from the Sarah Cannon Cancer Network West Florida Division. And we have Dr. Bleznak, chair of the CoC Accreditation Committee and a breast surgical oncologist at Riverside Health System. First, I would like to turn it over to Dr. Bleznak for his section, which is an overview of the self-audit process. Next slide, please.
Thank you. So good evening to all of you. I suspect that at least a few of you have heard parts of this presentation before, but we thought this would be a good opportunity to once more review the new internal audit process for standards 5.3 to 5.6. So I always like to begin these discussions with why are we making a change? Why are we foisting different work on you? Next slide. So in part, this is a reaction to comments we've heard from programs who have gone through 2 years of accreditation or reaccreditation visits and their feedback on the external audit process. We've learned a lot about the information technology challenges that you are all experiencing. We recognize that different electronic medical record systems impact your efforts to be compliant with these standards in different ways. And most importantly, we want to get the focus back on the intention of these standards, which is not documentation solely, but a focus on assessing whether these key steps for these important oncologic surgical procedures are being performed optimally. Next slide. So we're going to let you call the audibles. We're going to, again, make this an internal process, and the site reviewers like myself will be coming by every 3 years to make sure that you're doing your internal audits and doing them appropriately and reacting to the findings of those audits in an optimal fashion. Next slide. So what you see in front of you is the current state, which was developed, and hopefully you all heard about it and were educated on it beginning in 2020 and 2021 when the new set of CoC accreditation standards were released. The current state involves a site reviewer evaluating your performance based on an external audit where we select the cases, you provide us the operative reports, and if 80% of the operative reports meet the expectations of having all of the required elements in a synoptic section of the report with all the responses to those synoptic questions being appropriate, then you are compliant, and we evaluate this every 3 years. Next slide. So once we began doing site reviews in 2024, we very quickly recognized that programs were struggling with this. And rather than finding all of these programs non-compliant for these standards, which could affect their reaccreditation, we instituted what we called a deficiency resolve status, provided programs were doing internal audits, as many of you were doing, and developing an action plan to help you reach that 80% threshold. Next slide. And so this new process really builds off that deficiency resolve process. However, this is for a compliant rating, not a deficiency resolve rating. And so the new process expects programs or requires programs to, on an annual basis, perform an audit for each of these 4 operative standards. I want to emphasize these do not apply to standards 5.7 on totomesorectal excision and 5.8, which is lung nodal assessment. These only apply to 5.3 to 5.6. Next slide. And if your internal audit shows that you are achieving or exceeding 80% of the operative reports meeting all the expectations, and you'll understand these more completely when you see the templates in a few minutes, then you're compliant. If not, you can still be compliant provided you develop a detailed action plan. Next slide. So beginning January 1, 2026, these revisions to standards 5.3 to 5.6 became active. They require programs to perform on an annual basis an audit of up to 30 cases. If you have 30 or more cases, you need to audit all of them. If you have 15 cases, you can only audit 15 cases. In each case, your audit must include an assessment that all required elements are present in the operative report, that they are present in a synoptic format, that the responses to those required elements are all appropriate, and then you must perform the audit and record the audit in the CoC audit templates that you're going to see in a few minutes. And these will be what's reviewed by the site reviewer at the time of your reaccreditation visit. Next slide. Each year, the results of this audit must be reported to the Cancer Committee and documented in the minutes, and it must occur in the same calendar year as the audit was performed. Next slide. Okay, just to clarify, you must be performing the activities I just described as of this calendar year. If you are having a site visit in 2026, you will still be evaluated for calendar years 2023, 2024, and 2025 under the previous methodology of an external audit. Next slide. Okay, the reason that we turn this from an external, one of the reasons we turn this from an external to an internal audit is to allow the auditing of up to 30 cases. The more cases you audit, the better the likelihood that the results of the audit will reflect your actual practice. The smaller the audit, the converse. When we were auditing initially only 7 cases for each standard, there were a significant number of cases in which the results of the audit were not concordant with what was actually going on at that institution. We increased it to 15, but 30 is what the statisticians tell us would be the right number to minimize the risks of discordance between actual practice and the audit results. Next slide. Sorry about the timing here. Again, as I said on the previous one, all of this, the audit, an action plan if needed, and the reporting to the Cancer Committee must all occur within the same calendar year, and therefore you must make certain that you perform the audit prior to your final Cancer Committee meeting of the year. Next slide. Okay, while the action plan must be developed and presented to the Cancer Committee in the same calendar year, the action plan does not need to be completed in the same calendar year. Next slide. Okay, if you are a program who does not have 30 cases each year for any one of those operative standards, perform the audit prior to your final Cancer Committee meeting of the calendar year using as many cases as possible. I think I said the second bullet already, and the third bullet, again, I'll just say once more, you do not have to complete the action plan in the same calendar year, but it must be developed and presented to the Cancer Committee in the same calendar year. Next slide. Okay, if the audit shows 80% or more of the operative reports are compliant, you don't need to do anything further to receive compliance for that standard. However, if your audit demonstrates less than 80% of the operative reports have all of the required elements, appropriate responses in a synoptic format, then you must develop a meaningful action plan. This action plan must include a second audit within 6 months of the action plan being developed to make sure that whatever intervention you employed is having a positive effect. Next slide. If you do not achieve 80% of the reviewed operative reports meeting all the required criteria for 2 or certainly 3 audits in a row, and you keep presenting the same action plan, you will not be compliant. It will be a deficiency. Next slide. Again, what we hope to see from this transition is that the focus is on doing the oncologic procedure correctly and documenting it correctly, and move it away from being entirely on documentation. We've also recognized that during a 3-year accreditation visit, programs can improve. But when we're looking in aggregate at 3 years, you may not be achieving 80%. So therefore, the new process may will recognize those improvements and give you credit for it. It's been very burdensome both for you all and for the site reviewers to go back and forth trying to find 15 cases appropriate for review. And rather than waiting every 3 years to find out, hey, there's a way, we need to do this better, you will see this in real time. Next slide. For site visits, so if your site visit will be in 2027, you will be rated for standards 5.3 to 5.6 on your calendar year 2026 activity only. We're not going to do 2 years of an external audit and 1 year of looking at your internal audit. We will just look at 2026 activity. We'll review the audit templates, again, that you will see in just a few minutes. We will review the minutes to make sure that the audits were presented to the Cancer Committee, and if you had to develop an action plan, we'll review the action plan. Next slide. In addition, for educational purposes only, okay, we will select randomly from the cases you audit for each standard 2 cases so that we can look at the operative reports and make sure that you're doing the process correctly. Again, this will not impact compliance. Compliance will be based on your having done the audit and, if necessary, develop the action plans and making the presentation to the Cancer Committee. Next slide. Now, I've told you what is required for compliance. I want to tell you what we think is the ideal process for you to maximize the benefit from this. That the physicians, either entirely or at least in collaboration with oncology data specialists, perform the audit. This is one of the things that, as the quality champion for the cancer program, the cancer liaison physician should be involved. Next slide. The audit is on the synoptic section, and if the synoptic section is present and all the elements are there and the responses are appropriate, no other review is required. Next slide. However, if it's not compliant, the ideal process, not for compliance, but the ideal process would be that the auditor looks at the narrative section of the operative report, because that may describe that the technical aspects of the operation were correct, but that the issue was just in transferring that to the synoptic section. Next slide. If the operative reports do not have all the required elements, but it is present in the, if the synoptic section does not have all the required elements, but it is present in the narrative section, please note this in the comments column of the template. Again, the idea of this is to teach everybody these key steps of these oncologic procedures and assure that they're being done appropriately. Thank you very much for your attention.
All right, thank you, Dr. Bleznak. I'm going to take over for now, and I'm going to take us through specific examples of compliance and non-compliance and how these look within the self-audit tools. Next slide, please. So here's an example of one of the self-audit tool templates. Because of the way these project in the files, we've kind of broken them up into screenshots so they're a little bit more legible on a PowerPoint slide. But here's the general overview of the template structure. On the left of the template is basic case information. So if you look at the bottom left corner, you have a case identifier, which theoretically could just be numbers, right? We don't want MRNs or other PHI. And then a designated surgeon. And one thing I want to note, you'll see in the templates, is that the audited cases must represent operations from all surgeons who perform that procedure within the facility. So, for example, you have 6 breast surgeons. You should audit cases that span at least one case from each breast surgeon. Same would go for, say, your melanoma surgeons. So that's the case information. On the right side of the screen, you'll see required elements. And these required elements essentially mimic what is in the synoptic operative report. So these will look very familiar to you. The verbiage that is in the synoptic report is mimicked here. And below that are examples of, what a compliant answer would be, or reasons for a non-compliant answer. And that will help you fill out the audit template. And this will make a little bit more sense once we go through a couple of the examples. One thing I also want to point out before the next slide is there is a nice reminders section for each of the standards. So right now we're looking at 5.3, which is sentinel lymph node biopsy for breast cancer. In that reminders box are some nice tips for what cases would qualify for specific metrics, and these will be helpful clarifications if you're looking at a case and you're wondering, well, would this one fit or not? Like, for instance, a prime example would be an operation for curative intent. For 5.3 and most of the other synoptic operative standards, these are for operations that are performed for curative intent for the patient. Next slide, please. So I'll take us through this. At the top, again, is really just a snapshot of the required elements for 5.3. There are several of them. This is one of the longer synoptic operative report templates. So that's just an example of that. In the bottom left, I want to direct your attention to the compliance summary. This on the Excel spreadsheet, it really just kind of drags from left to right as if you're reading a book. And so on the right-hand side of your Excel spreadsheet, you'll see a compliance summary section. This is where you document if the case itself was overall compliant or non-compliant. And then if it was non-compliant, you will select whether it is a technical non-compliance, a documentation non-compliance, or both. Technical implies that the surgeon did not do the operation steps for that synoptic operative report technique correctly. For instance, and we'll get into some examples, but say a step was omitted. The documentation non-compliance would be, you look through the narrative report and yeah, the surgeon did all the steps appropriately, but the documentation that relays that in the synoptic session is not filled out correctly. That would be a documentation error. And then there will be instances where you find both. And so if that is the case, you fill out both. In the bottom right is a snapshot of the summation of all 30 cases, or up to as many as 30 as you can get to at your site. And so you'll have a total number of cases which are compliant and then a percentage. And you would hope that the percentage you hit is 80 or above. And if not, you'd be forming an action plan. Next slide, please. So for 5.3, I'm going to walk us through two examples. So example one, we'll just say Dr. A. This is a compliance case. This is the one where the surgeon designated in the synoptic report that it was performed for curative intent. They documented that they used 2 tracers for sentinel lymph node biopsy, the dye and the radioactive tracer. And then in the tracers used for sentinel lymph nodes in the neoadjuvant setting, this patient did not have any tracer for that because they were not in the neoadjuvant setting, so it was just not applicable. In case number 2, this is Dr. B. This was a patient that had neoadjuvant therapy. It was for curative intent, so they marked that yes. And then in the section for the tracer, they used dye. Next slide, please. In case number 1, if you continue to follow from left to right, you'll notice that all of the synoptic elements are answered yes, and these are correct. This would be a compliance case. In case number 2, there is non-compliance because the surgeon answered no for all significantly radioactive nodes being removed during the procedure, and they answered no for biopsy-proven nodes marked with clips prior to chemotherapy were identified and removed. Those are 2 steps that are critical for this standard. And so that would be both a documentation error and a technical error. Next slide, please. And this is what it would look like in your compliance summary section. So in case number 1, that was a compliant case. All the answers were correct. So you see in the column there that is compliant. In the second case, it was non-compliant. It is labeled as such. And then for technical, documentation, or both, this was answered as both. Next slide, please. I would just like to highlight, where the documentation error comes in, because you may see this frequently. So in some of the columns, for instance, the one highlighted with a circle, I think, yep, click, thank you. Some of these just require an explanation. So a portion of the required elements for the procedure can be omitted if there's some particular anatomic or other patient-related reason why it couldn't be performed, but the surgeon then has a free text option to provide an answer as to why that occurred. If they provide no explanation, then that is a documentation error. Next slide, please. Moving on to standard 5.4, this is for axillary lymph node dissection for breast cancer. Very similar formatting. Again, you have your reminders section to help you with identifying cases that would be, part of this standard. And then you have the same sections with case information, the required elements from the synoptic operative reports, and a compliance summary. Next slide, please. So if we look at case number 1, this represents a compliant case where Dr. A performed an axillary lymph node dissection within the proper anatomic triangle. So they answered yes for that question. They checked off that they were within the boundaries of the axillary vein, the chest wall, and latissimus dorsi. They then also protected all relevant nerves during this dissection. So they checked the boxes for long thoracic nerve, thoracodorsal nerve, branches of the intercostobrachial nerves. And therefore, because of those correct answers, this would be a compliance case. If you look on the right-hand side of the slide, it is labeled as such. Now compare that to Dr. B, or case number 2. This surgeon did not specify the nerves that were protected during the case, and they selected other. However, when they selected other, they did not complete a free text explanation as to why they didn't protect these nerves. So this would be coded as a non-compliance case, and it is both a technical error because they did not protect the nerves that you need to during an axillary lymph node dissection, and also when prompted, they didn't provide any free text explanation as to why that occurred. Next slide, please. This is the template for 5.5. 5.5 is wide local excision for primary cutaneous melanoma. Again, looking very similar to the other audit templates. The key to this self-audit is determining if the surgeon selected the proper margin width based on the original Breslow thickness of the biopsy that was available to them prior to the wide local excision of the primary melanoma. Next slide, please. So case 1 represents a compliance case. So Dr. A performed a wide local excision. The initial depth of biopsy was 1.3 millimeters, and the surgeon selected a 1 centimeter wide local excision margin. And they performed that for the depth of excision to the right of that for a full thickness skin, subcutaneous tissue down to the fascia, and that is the standard for melanoma. And so they selected the proper margin and they did it to the proper depth. So that would be a compliance case. Dr. B, in the second case, had a Breslow thickness of the biopsy to 2.5 millimeters. And at that depth, the proper margin would be 2 centimeters. This surgeon performed this to 1 centimeter and selected that in their synoptic op report. And so that would be a non-compliant case, and the reason for that would be labeled as technical. Next slide, please. Lastly, we have the audit template for standard 5.6, which is colectomy for colon cancer. This particular template has several free text fields instead of drop-downs. However, they are quite intuitive to fill out. Next slide, please. So as an example, for case number 1, we have Dr. A. The surgeon performed a transverse colectomy for cancer. They appropriately selected that they performed a transverse colectomy, and then also that they ligated the middle colic pedicle. So again, as a reminder, standard 5.6 is a technical standard where the surgeon does a high ligation of a vessel that feeds the segment of colon that has the cancer in it. And so because they selected the correct segment of colon with the appropriate vascular pedicle that feeds that section, this is a compliance case. Case number 2, Dr. B, performed a ascending colectomy or a right colectomy, but if you notice, they didn't select any vascular pedicle at all and did not indicate that they performed a high ligation. So this would be a great case to look through the narrative of the operative report and try to sort out whether they dictated that but didn't document it properly, or if they truly did not ligate the vessel or do a high ligation of that vessel at all. And so for this specific example, let's just say you audit the case, and in the narrative report, you also see that they did not do a high ligation or dictate that. So this would be non-compliant for both a technical and a documentation issue, and so this is labeled as both. Next slide, please. So that terminates the section for examples for both compliance and non-compliance with each audit template. I would like to turn over to our next panelist, Carrie Antonelli, to discuss registrar considerations, and thank you for joining us.
Hi, thank you, Dr. Villano, and thank you, Dr. Bleznak, for the information and the demonstration to assist with these new templates. So just want to talk a little bit about, if you could go to the next slide. Just wanted to talk a little bit about if the registrars are the ones completing the audit or assisting with the audit, You want to start out by identifying some gaps and trends, and this is going to help you all develop a meaningful action plan. So when we're performing those audits, we may come across some challenges, whether it's the surgeon actually using the template that's been created at our programs, or are they missing technical and documentation errors? We want to go back and think about what Dr. Bleznak said earlier. How are we going to react? Well, let's identify those gaps and trends. And again, that's going to help draft those meaningful action plans. So you'll want to track patterns, not just the one-off misses. What element is consistently missed? And is it one surgeon who might be missing some certain elements? Once you identify that, you want to escalate and try to make that change. So identify that surgeon who might be missing certain elements, and then use your template that you just completed to help communicate and escalate to a surgeon champion, or even maybe a contact in leadership to help with that communication to try to make those changes. And remember, this is not blame. This is a process improvement, and we work with process improvements all the time based on data that we look at every day. And just remember to include that the reason for your repeat audit should be included in your action plans, and have that separate action plan for each of the operative standards. Of course, if your compliance is below that 80%. And that's all I have.
All right, thank you so much, Carrie. So for our next section, we're going to turn to the Q&A. I'm going to look through the questions box here and pick through some things that have not been answered already. I think this was answered somewhat by Dr. Bleznak, but I do think it does deserve some reemphasis. So Dr. Bleznak, just remind us, who is responsible to conduct these audits in your opinion?
So we did not designate a responsible individual. However, I think that this should definitely include the cancer liaison physician. And I think that ideally, the audits of operative reports, especially if you're going to look back into the narrative section, should really include a surgeon. Obviously, surgeons should not review their own charts. If they have a blind spot, if they are unsure of a particular element or the correct response, when they audit their own chart, they're going to bring that forward with them. So there's no learning involved. But you will be compliant regardless of who does the review.
All right, thank you, Dr. Bleznak. Great answer. And as a CLP at Fox Chase, I would just echo that. I think really as Dr. Bleznak had highlighted, the sort of intent here is the process of learning from the audit and what we can improve. And so I think in an ideal setting, a physician who's a quality champion, such as the CLP, would be reviewing these alongside data abstractors. I'm just looking through our Q&A here. Kind of identify a couple common themes. There's a lot of questions, which is good. Let's see. So I think I know the answer to this, but I'll pose this again to Dr. Bleznak. One of the questions is 5.7 and 5.8 are not within the scope of this webinar, but 5.3 to 5.6 have these CoC templates. Is there going to be any internal audit process for 5.7 and 5.8, or are those excluded?
So programs have done internal audits for 5.7 and 5.8, but that is not, I repeat, not being used for compliance. Compliance for those two standards is by an external audit of 15 pathology reports for every 3-year cycle. So we will be selecting from a case list you provide a total of up to 15 cases for 5.7 and 5.8, and we'll review the pathology report. So that's still an external audit.
All right, thank you for that clarification. Let's see here. So this is a good one. So and there's a couple questions that have a similar theme with this as well. So does the audits have to be surgeries done in 2026? Some registries abstract cases 6 months after diagnosis or the date of first contact. I guess part of that question would be, I would assume they're trying to get at, would they review any cases from 2025, or should we just start January 2026 and on specifically?
So I would say that it benefits programs to do the most recently available cases, because a lot of you have, your IT departments have struggled to develop the synoptic section for your operative reports. And so to go back, the further back you go, the more likely you are to find cases that will not be compliant. I would say that for 2026 reviews, I would not go back any further than the second half or beginning Q3 of 2025. And then if I was doing a 12-month cycle to get my 30 cases or up to 30 cases, then I would try and use the same time frame for each subsequent year's internal audits. I hope that's clear.
It is, thank you. I'm just gonna take one moment. There are quite a few questions. Just trying to figure out which ones are most relevant here. This is a good one. So, and I'm not sure. I know the answer to this one, Dr. Bleznak. If you're an integrated network program, so you have numerous campuses, is it advisable to have at least one case from each campus?
So you need 30 cases per facility. All right, so it's not a total of 30 for your entire network. It's 30 per standard per facility. Now, or up to 30 cases. You don't have to do, obviously, any more than that. So if you have 10 facilities in your network, you're doing an audit of 30 cases for each of the 10 facilities, or 300 cases.
Sounds good. That makes sense. One question. This is a good one.
Tony, can I just,
sorry, go ahead.
Can I just clarify that?
Yes, please.
Or not that, but just clarify this. Again, the goal is to do an audit of a sufficient size that you understand what is going on in your facility reliably. The fewer cases you audit, the more likely that your audit may be non-compliant when you are really compliant. So 30 is the number that statisticians say begin to approximate a normal bell-shaped distribution curve. So that's why 30 cases were selected.
Sounds good. That's clear. I'm going to answer one of the questions that referred to the way that these appear in the audit when someone selects other. So to highlight that, there are sometimes, and it should be pretty rare, but there are sometimes situations where a surgeon may encounter a situation in the operating room where a technical aspect of that is reflected in the standard requires them to select other because they could not perform it in the way it would be outlined in the synoptic report. And on a very rare occasion, that could happen. That would still be compliant as long as the surgeon then, they will be prompted in that when they select the other to have a free text selection as to, what was the reason why this occurred. As long as they can provide a rationale that makes sense for that particular case, that would not be considered non-compliant. It is an issue, a documentation issue, though, if they select other, but then they provide no rationale and no explanation as to why the metric could not be met. And then specifically too, as if that is a case you select to review with your CLP or others, you go to the narrative section, and again, there's really no reason why that technical aspect couldn't have been performed, then that is non-compliant. So I think an other answer without an explanation begins as a documentation issue, a documentation non-compliance, but then may become technical if you go back and review the narrative. So I think those specific cases should prompt a review of the narrative report to clarify. And I think there was a couple questions about that, so hopefully that addresses that accurately. One of the questions is, I have a question about the original Breslow depth. If the reread of the original differs, the one done at your hospital, do you use the original pathology or the one at your hospital? It is a bit of a gray area, I would say, but I could just answer specifically. This is a common situation at my hospital. I on occasion do melanoma. We tend to use our internal review of the Breslow depth. So if our pathologist review differs from the outside, and then the surgeon who is taking care of that, we tend to go with what the Breslow depth of our internal review was, not what the original outside pathology was. And I don't know if for any of the breast standards that would even apply to the Bleznak, but in your review of other institutions, has that been a general practice? They use the Breslow depth of their own internal pathology review if they've re-reviewed the slides.
Yes, I mean, I think what you're asking for in this standard in 5.5, but in the others too, is what situation did the surgeon think they were facing when they performed the operation?
Yes, agree. Let's see. A lot of questions about the timing. It seems like a lot of sites are pulling cases at different time periods throughout the year in terms of their quarterly cancer meetings. Specifically, Dr. Bleznak, would the fourth review of this data in the fourth quarter cancer committee meeting, is that in your mind a hard and fast rule, or if specific cancer centers want to make an annual rotation at their Q3 meeting or their Q2 meeting, is that ultimately acceptable, or should they really be focusing on trying to have this review
So the purpose
occur in their fourth quarter meeting?
Right. The purpose of these standards, I'm hoping that this answer will help people think this through. The purpose of these standards is to make sure that your surgeons are doing the cancer operations correctly for the benefit of your patients. That's why you're doing the reviews. Okay, you want to make sure that the review gives you an accurate assessment of what's going on at your institution for each of the surgeons that you have available. If you have 300 breast cases, you can finish your breast, you will probably get your 30 sentinel node cases in the first quarter of the year. You can do that review in the first quarter of the year. If you have 50 breast cases, then I think ideally, as you go through the year at certain intervals, those cases will be reviewed, hopefully by the cancer liaison physician or a breast surgeon that they designate, and then you can stop whenever you achieve 30 cases. If prior to your fourth meeting, your final meeting of the year, whether you have 4 meetings or 6 meetings, you don't have 30 cases, do the audit on the cases that you have. If I am the site reviewer and you have 40 breast cases and you've only reviewed 25, you're going to be compliant. If you have 200 breast cases and you've only reviewed 25, you will not be compliant.
Thank you for that. Another good one for you, Dr. Bleznak. If, say, an institution is reviewing their cases and they find cases with a purely documentation issue, say they read the narrative and it looks like the surgeon just, misclicked or just had an issue with filling out the synoptic report.
Then that
Can
case
they
is
go
not-
back and addend that operative report to then bring it to compliance?
So yes, I think if you find that there is an error with the synoptic reporting, then yes, you can go back, but not if it occurs during the audit or your official audit. Again, I would be very loath to go back and reopen an operative report. If God forbid that case ever comes for a legal review, they will know the last time that note was altered, and that puts the entire note, I guess, at some question. So I do not recommend going back and changing an operative report or addending an operative report just to put the synoptic section in. I mean, again, you are compliant as long as you do the audit and come up with an action plan. And in this case, your action plan should be to make sure that all the surgeons know they have to put in the synoptic report. That's why we've changed the standard, to try and disincent the need to do that and incent the need, or incent the focus on whether the operation's being done correctly and documented correctly.
All right, thank you for that. A couple questions about timing of the action plan. So say, that they get to the end of the year, they do their audit, and they need to form an action plan. Does that audit then need to be within the audit, and then maybe the re-audit, if indicated, would that be within the same calendar year? I suspect this would be rolling into the next calendar year. Is that correct?
Absolutely. Yes, absolutely. That's correct. So let's say you do your audit in Q3 of 2026, and you develop an action plan because you're not achieving 80%. Okay, if you have enough cases, your next audit could constitute your 2027 audit. Okay, so again, we're not trying to make you do extra work. What we're saying is that if you're making a change to try and achieve compliance in a reasonable time frame, you have to do a subsequent audit to find out if it's working. If you only have 20 cases a year, you probably will have to do a separate audit. But again, that's, the important thing is that your action plan contains the plans to do a repeat audit, and it, in most cases, will probably not be in the same calendar year.
All right, thank you for that clarification. Apologies to everyone. Just one moment, just kind of reading the comments coming through and seeing if there's anything new here that we haven't touched upon. So I see one comment, and I'll just answer that. So yes, this is 30 cases per standard, not 30 total for all of the operative standards 5.3 to 5.6. So each standard you're reviewing up to 30 cases. And again, if you're doing less than 30 cases annually, you will review as many as you can. So I hope that clarifies. Just one more moment, just looking through to see if there's anything new we haven't really touched. Some of these are some of the same. So for programs that are applying in 2027, what would the required compliance for that program be? I'm presuming it's the same. It'd be 80%, right, Dr. Bleznak?
Yes.
I think it's 80% across the board.
Yes.
Yeah.
Again, because to achieve compliance with the standard, you have to do an audit and assess where you are. If you're at lower than 80% of the operative reports meeting the expectations, you need to do an action plan. Either achieving or exceeding 80% or doing the action plan will still result in compliance for that year.
Let's see. So another good question. Kind of gets back to the INCP thing. Expect there are a lot of INCPs out there. So say a INCP has 7 facilities. Then each of those facilities would do a 30-patient audit for each standard. Correct, Dr. Bleznak? So that would be, I mean, in the math in my head, it'd be upwards of like 800 cases. But that would be correct, right? Each facility.
Right, that would be upwards of 800 cases total for standards 5.3 to 5.6. That is correct.
And if this particular INCP is similar to the one I work at, some facilities do less volume, and so it may not be that you get to 30 at all of them for every standard, but I think the intent is that you are reviewing all of these standards at all of your facilities to the volume that you can get to for up to 3.
Right. Again, we are not going to come in to do a site review, pull your list of cases and say, wait a minute, you did 32 sentinel node biopsies in 2026 and you only audited 28. Nobody is going to do that. 30 was chosen because it gives your institution the best opportunity to have your audit reflect what's actually being performed and not to have a discordant result. That's why 30 was selected. Okay, but I think you're absolutely right, Tony. I think it is very unlikely that every site is going to have at least 30 cases for each of these standards. We're frequently seeing programs, there are, unless you're a really major breast center, you're not doing 30 axillary node dissections in 2026 because the guidelines to do those have become so restrictive. And a lot of places aren't seeing 30 melanomas.
Yeah. To that vein, I know we're running close to short on time, but the good question here, again, sort of like an INCP question. If you have 5 campuses, 4 out of the 5 campuses have achieved 80% or higher compliance, but 1 is not, would that deficiency then require an action plan specific to that site within the INCP?
And since the goal is to have the surgeons at that site doing the operation correctly, the answer is yes, you would need an action plan for that site.
And I'll answer this question because this one is an important point. So if a site has less than 30 cases, the question is, do we go back and include cases that were performed without curative intent to increase the number of cases reviewed? I would suggest that that is not the case because usually for palliative intent cases, the operations may not even be performed in the same way because they are for different purposes. All of these operative standards are strictly for patients who are undergoing curative intent. And so that is always the first question in the synoptic report that the surgeon fills out and is the first column in the audit tool so that you specifically are choosing just procedures of the curative intent. And if you can't get to 30, that is okay. You don't want to pick cases that are for palliative intent.
That's absolutely correct.
And I think we're at the time end. We have 1 or 2 more slides. So I'm going to move along, but we will send out answers to the other Q&A questions and post them to the site. I just want to give a special thanks to Carrie and Dr. Bleznak for joining me tonight, being very generous with their time, to the CSSP leadership and staff that have put in all the work for this, to our ACS Cancer Program staff. Next slide, please. A reminder for the Quality, Safety, and Cancer Conference, which is coming up in July in Orlando. It'll be an excellent conference, and much of the same information coming. I'm sure there'll be great reviews of this at the conference as well. Next slide. Here are QR codes to direct you to some of our online resources and our social media, a plethora of information at all of these. So I welcome everyone to browse these, and I think you'll find many answers to common questions here. Next slide, please. And lastly, on-demand content, which is exciting and now available. I won't list all of them here, but I do direct everyone to the QR code in the bottom right. Really great on-demand content and sort of up-to-date information for all of these initiatives and new breaking events at the ACS. And I think that's it. So thank you everyone for your time and attention tonight.